This is part 2 of the series of radiographic assessment of bone lesions, classification of tumors. I'm basing this lecture on the 2012 edition of the World Health Organization classification. Keep in mind, though, that it's not uniformly applied and you may see different terms and classifications. In the past, tumors were classified by the cell line of differentiation, and this works fine for cartilage and bone-forming tumors, but not so well for those that lack recognizable differentiation. And an example would be Ewing's. The new classification now uses combination of morphology, phenotype, and genotype. So immunohistochemistry genetic techniques have all changed the way tumors are classified, and they'll continue to do so. In the WHO classification, there are 4 categories of bone tumors: benign, intermediate locally aggressive, intermediate rarely metastasizing, and malignant. But this doesn't always equal the categories that I used in the first video, which are based on imaging. And the WHO categories only include tumors, but the imaging categories also include non-tumor lesions such as infection. The benign category has limited capacity to recur, and they're usually cured by resection. The intermediate locally aggressive category, they often recur locally. They're destructive, infiltrative. They do not metastasize, but they do require a wide excision. An example would be grade 1 chondrosarcoma. The intermediate rarely metastasizing lesions are similar, but occasionally can metastasize, and that's usually to the lung. And this can't be predicted by histology. An example would be giant cell tumor. Finally, the malignant category often results in metastatic disease, depending on grade. So here's the list of groups, and most of these also contain several tumors within each of the groups. I'm not going to cover all the tumors on the WHO list, but I'm going to emphasize the ones I think you need to know. The top 2 are the major categories, osteogenic and chondrogenic, and then there's the fibrous, and then finally under miscellaneous there are quite a few different types of tumors. First up are the bone-forming tumors. In the benign category, there's the bone island and the osteoid osteoma. In the intermediate locally aggressive category, there's osteoblastoma, and in the malignant category, there's osteogenic sarcoma. A couple of examples of bone islands. These are also known as enostosis. They're common, thought to be developmental rather than neoplastic, and they occur in all age groups. They can be in any bone, and histologically, they're normal cortical bone, but in an atypical location. On X-rays, they show bony spicules with a thorny outline. The next bone-forming tumor is the osteoid osteoma. With these, you'll see a lucent lesion surrounded by sclerosis, and it's usually near the cortex. They happen in younger patients. The classic symptom is night pain relieved by NSAIDs, and I put this in red, the pain in red, to emphasize that it's disproportionate to the size of the lesion. They can be in any bone, but tend to be in the femur and tibia, and they can also be in the posterior elements of the spine, hands, and feet. Another classic finding is painful scoliosis. With an osteoid osteoma, the nidus is the actual tumor, and it has a variable amount of mineralization, so it either can be lucent or sclerotic. The nidus is usually surrounded by reactive bone sclerosis, and there can actually be so much sclerosis that it obscures the underlying tumor. These could be cortical, medullary, or subperiosteal. Intra-articular lesions are often missing the surrounding sclerosis, and they can cause an effusion, so something to think about with an unexplained effusion. The key to osteoid osteoma's diagnosis is to find the nidus, and CT is the best way to go for that. An example of a tumor appearing as a lucent lesion with just a little sclerosis. The next bone-forming tumor is the osteoblastoma, sometimes considered a large osteoid osteoma because histologically they're similar. There are a couple of differences in these besides the size. They may or may not have pain, and when they are painful, it may be that it is not relieved by NSAIDs. They're also seen in painful scoliosis because they occur in the posterior elements of the spine and sacrum, and while they can occur in the long bones, an osteoid osteoma is more likely to be present if it's a long bone lesion. They also have a higher rate of recurrence than the osteoid osteoma. Here's an example of an osteoblastoma appearing more aggressive with a mixed sclerotic and lucent appearance. And this usually happens when these tumors occur outside of the spine. They can look like aneurysmal bone cysts, and they have those elements. Osteogenic sarcoma is the malignant type of bone-forming tumor. They usually occur in the young, but they can occur in older patients, and they have a male predominance. Common sites are the metaphysis of femur, tibia, and humerus, the place where the growth is most active. They're a mixed sclerotic and lucent lesion with aggressive periosteal reaction, and you can see a Codman's triangle. Here's an example of one showing a very aggressive periosteal reaction. The most frequent sites of systemic disease is the lung, followed by bony metastases. Another aggressive appearing lesion with aggressive periosteal reaction. The image on the right shows a wide zone of transition telling us it's an aggressive lesion, examples of osteogenic sarcomas. And osteogenic sarcomas can be further classified into the following subtypes. And this mainly is to show that there are many subtypes rather than to suggest you need to know them all. And the conventional is the most common. There's also telangiectatic, which is purely lytic and will have ABC elements, so on MRI you can see fluid levels. The small cell variety can look like Ewing's or lymphoma. There's the low-grade central that can look like fibrous dysplasia or fibrous cortical defect. And then there's secondary lesions. The juxtacortical type consists of three types, and I wanted to point out that the term juxtacortical used to be synonymous with parosteal, but in the newer system it's actually easier. The parosteal, periosteal, and high-grade surface types are now all considered juxtacortical osteogenic sarcoma. So to break down conventional even more, we have the following subtypes, and again, this is just to show that there's many subtypes of conventional osteogenic sarcoma, with the osteoblastic being the most common. This isn't to suggest you have to know all of these. The next category are the chondrogenic tumors. Here's the WHO classification based on the groupings mentioned earlier: the benign, intermediate locally aggressive, intermediate rarely metastasizing, and the malignant. This image shows how bizarre these can look. And on the MRI on the right, note that the medullary space extends into the lesion, and this is an important feature for osteochondromas. And while they're usually easy to diagnose in long bones, when in flat bones they can be harder to diagnose, but they're less common in flat bones. The MRI shows what the cartilage cap looks like. One sign of malignant transformation is thickening of the cap, but you'll need an MRI for this. The risk for malignancy is actually low for solitary osteochondromas. It's about 1%. It is higher for hereditary types with multiple lesions. The next lesion is the chondroma. And to clarify the terminology, chondromas are actually divided into two types. The central chondroma is almost always referred to as an enchondroma. But there's also the periosteal chondroma, and this is also known as a juxtacortical chondroma. If you see a lesion in a digit, you want to think of enchondroma because they're the most common lesion in the hands and feet bone. In the central skeleton, you have to consider lesions like chondrosarcoma. The expanded appearance in the digits make them look very aggressive, and they're usually solitary and asymptomatic. The only time malignancy is a concern in the digits is when they're multiple in Ollier's or Maffucci syndrome. These will also be in long bones, where they're often seen on chest radiographs incidentally. When seen in the long bones, it can be difficult to tell the difference between an enchondroma and a low-grade chondrosarcoma. Things to consider are the larger size, cortical breakthrough, and pain, findings that suggest a chondrosarcoma instead of an enchondroma. A much less common benign cartilage-forming lesion is the chondroblastoma. They're usually seen in teens and are usually painful. They have a characteristic epiphyseal or apophyseal location, with the femur being the most common. They also can occur in the talus, patella, and flat bones such as the pelvis. Chondroblastomas are usually sharply demarcated with or without a sclerotic border. A matrix is seen in about a third, and the main differential is going to be clear cell chondrosarcoma, and this is just something you need to know because clear cell chondrosarcomas can be so well defined. So you want to think of a clear cell chondrosarc when you see what looks like a chondroblastoma in an older patient, Ultimately, though, you may not be able to tell the difference. And on MRI, chondroblastomas can often be surrounded by quite a bit of bone marrow edema. Another rare tumor is the Chondromyxoid fibroma. Of the cartilage tumors, these have the least specific appearance. They're also seen in younger patients and can occur in any bone, with the proximal tibia being the most common. They tend to look like aneurysmal bone cysts and usually don't contain much matrix, but they can have a trabeculated appearance. Think of a chondromyxoid fibroma when you would also consider an aneurysmal bone cyst. Finally, the more common and malignant cartilage lesion is the chondrosarcoma. And this you will see. They're often seen in the pelvis, but can be at the end of long bones. They can be in the ribs. They're actually rare in the hands and the feet, where you're going to see an enchondroma. Most of these have a cartilage matrix, but not always. There are subtypes, and as with osteogenic sarcoma subtypes, the slide is just to show that they exist. These include the conventional clear cell, juxtacortical, etc. Here are a couple of typical appearing chondrosarcomas. They look like enchondromas, but they're larger with more endosteal scalloping. And these are a couple of findings that make you lean towards chondrosarcoma rather than enchondroma. And you also want to look for periosteal reaction. Another thing that can help you determine that this is a malignant chondrosarcoma is when you see a soft tissue component. And this one shows cartilaginous matrix within the soft tissues adjacent to the pelvis. The next type of tumor is the fibrous, and I've included both the fibrogenic and fibrohistiocytic origin lesions under the fibrous origin. The first is the desmoplastic fibroma, a really rare tumor that's in the intermediate locally aggressive category. They're also known as desmoid tumors of bone because it's the bony version of the more common soft tissue desmoid. On radiographs, they are expansile lesions. The fibrosarcoma is the malignant tumor in the category and appears aggressive radiographically. The other group of fibrous lesions are the fibrohistiocytic lesions, and here you only really need to know about non-ossifying fibroma or fibrous cortical defect because they're very common. Benign fibrous histiocytoma of bone won't be discussed further. Note that sometimes fibrous dysplasia is included. The fibrous cortical defect is the most common lesion, also known as a fibroxanthoma. The fibrous cortical defect is sometimes known as a fibroxanthoma, and the names fibrous cortical defect and non-ossifying fibroma are often used interchangeably. Some use 3 centimeters as a cutoff, with the NOF being the larger and in the medullary bone, while the fibrous cortical defect is smaller and cortically based. These are seen in young patients and tend to regress over time. The image on the right shows that the lesion can have a bubbly appearance. Next are the tumors of hematopoietic origin. All of the lesions in this group are malignant and include the plasma cell myeloma, which is usually known as multiple myeloma, solitary plasmacytoma of bone, and primary non-Hodgkin lymphoma of bone. The plasma cell myeloma, or multiple myeloma, is the most common primary malignant bone tumor and tends to occur where there's a lot of red marrow, the axial skeleton, but it can be seen anywhere. When it's solitary without systemic involvement, it is known as a plasmacytoma. And with multiple myeloma, you usually see multiple well-defined lytic lesions without sclerotic borders, and they can be expansile, especially in the long bones. Along with Mets, this should be considered in just about any lesion in an older patient. Lymphoma of bone is usually secondary to systemic disease. Primary bone lymphoma is very rare and is usually of the B cell type. It occurs in the axial skeleton and also in the long bones and appears very aggressive with a permeative appearance, but it can be mixed. The next group is the osteoclastic giant cell-rich tumors and contains 2 tumors, the giant cell lesion of small bones, also known as the giant cell reparative granuloma, and then there's the giant cell tumor of bone, the one we're going to focus on. The giant cell tumor is considered a benign but locally aggressive lesion and occurs in patients with closed growth plates. They're classically seen at the end of long bones abutting the articular surface. There's no matrix. there should be a sharp zone of transition without a sclerotic border. They can appear very aggressive, often associated with secondary aneurysmal bone cysts. Notochord tumors are another class of tumors containing two entities. The benign ones are very common but usually don't cause symptoms. It's either due to persistent notochord or developmental, and they don't have a soft tissue component. The chordoma, on the other hand, is the malignant lesion, often with a large soft tissue component. They tend to occur in the sacrum and the clivus. Another category is the vascular tumors, of which the hemangioma is by far the most common. These are benign tumors of vessels, and usually we'll see coarse striations radiographically. They're most common in the vertebral bodies, although they can occur elsewhere. For the myogenic tumors, leiomyosarcoma is the only member and is rare and won't be covered further. For lipogenic tumors, lipomas are very common in the soft tissues, but they can occur in the bone, usually in the femur calcaneus. They can rarely be parosteal, often have a characteristic central calcification due to calcified fat necrosis. Liposarcomas in bone are very rare. The undefined category contains quite a few tumor types, including the following, of which I'm going to cover the underlying ones: aneurysmal bone cyst, fibrous dysplasia, simple bone cyst, and Langerhans cell histiocytosis. Now we're on to the intermediate, locally aggressive category of tumors of undefined neoplastic nature. Aneurysmal bone cysts are thought to represent non-neoplastic lesions related to venous obstruction or an AV fistula. They're composed of multiloculated, fluid-filled cysts that you can see radiographically, usually on MR. And so you'll see fluid levels, and they can be on their own or secondary, with giant cell tumor being the most common, but also they can be seen in osteoblastoma, chondroblastoma, fibrous dysplasia, and even osteosarcomas. They can occur in any bone and appear as an expansile, blown-out lesion. They tend to grow fast, and that's why they can look aggressive. The simple bone cyst is otherwise known as a unicameral bone cyst, and they're seen in any bone, but most frequently in the proximal metaphysis of the humerus and femur, generally in young patients. They're sometimes seen incidentally, but also they can present with pain because of a fracture. Here's a fracture in the simple bone cyst with the fallen fragment sign. The fragment floats to the bottom of the lesion, indicating that it's cystic and that it's not solid. And don't let the trabecular appearance fool you into not including it in the differential. And here's an example of a simple bone cyst in the calcaneus. One of the more interesting lesions on the list is one that the WHO system actually classifies as a miscellaneous lesion with undefined neoplastic nature. Fibrous dysplasia can occur in any bone but likes the long bones. When in the flat bones, it can look cystic or chondroid, so you have to keep that in mind along with infection in just about any bone lesion you see. Unless I see something very characteristic like an aggressive sclerotic osteogenic sarcoma, the first thing I ask myself is, can this be fibrous dysplasia or infection, and then metastatic disease in older patients? It often expands the medullary cavity and classically has a ground glass appearance. They're usually monostatic but can be polyostatic, especially if they're part of a syndrome like McEwen-Albright. Another example showing an expanded appearance. Here's some examples of different appearances of fibrous dysplasia. The one on the right is the polyostotic form, and this tends to be on one side of the body. The next of the locally aggressive tumors is Langerhans cell histiocytosis. Sometimes you may hear this referred to as eosinophilic granuloma, but that's considered an outdated term. It occurs in kids and is usually solitary, but can also be multiple, and it has a variety of appearances. It can appear very aggressive, especially in long bones, whereas in the skull it has the characteristic well-defined lesion with a beveled edge. And this is a lesion that you should consider in kids, just like you consider metastatic disease in adults. In just about any lesion, think of this. Another common lesion that can fool you into thinking it's a tumor, such as a giant cell tumor, is the geode. While it's not in the WHO classification, you're going to see these, so I included it. They're often seen at the articular ends of long bones, and when it's related to osteoarthritis, it's often referred to as a geode, otherwise an intraosseous ganglion. The first of these is Ewing sarcoma, and these occur in younger patients, usually in the diaphysis of long bones, but also in the flat bones. They have a permeative, aggressive appearance with cortical destruction. They can have onion skin periosteal reaction, and in this case, you see a very aggressive periosteal reaction, so you have to think of a Ewing sarcoma when you see this, and often they'll have a soft tissue component. The Adamantinoma is a low-grade malignant lesion. It almost exclusively occurs in the anterior tibia, and it's usually well circumscribed, multilobulated, with septations and peripheral sclerosis. They're often multifocal. The undifferentiated high-grade pleomorphic sarcoma is also known as the malignant Fibroshistiocytoma, but it was recently renamed because of the lack of specific cell line of differentiation. This occurs in long bones. Metastatic disease is common, and a fibrosarcoma has similar appearance radiographically. Finally, I added metastatic disease infection and brown tumors to the list. Metastatic disease should be considered in just about any lesion you see in an adult. It's much more common than in primary bone tumors. They can be sclerotic, lytic, mixed. They can look just about like anything, and mostly you see them in the axial skeleton. Common primaries are breast, lung, renal, and thyroid cancers. Metastatic disease can be obvious or subtle radiographically. If you look at this film and try to see the finding, you'll see that there is a destructive lesion in the lesser trochanter. But there is also another thing, and that is the destructive lesion in the acetabulum. So some of these can be pretty subtle radiographically, and if you were to do an MR, you'll see that it's much easier to see these lesions. They really stand out. More examples. This is an example of sclerotic mets. And a brief word on brown tumors. They're actually not true neoplasms. They're more common in primary hyperparathyroidism, but since you see more patients with renal failure, if you're going to see them, it's more likely secondary. They can appear aggressive, and they can be hard to tell from giant cell tumor or fibrous dysplasia. Finally, infection has many appearances depending on the patient's age, the type of spread, hematogenous or direct spread, the location, and the chronicity of the infection. These all influence the way it looks. If active, they can appear very aggressive. If chronic, you may see more bony reaction. And the infection most likely to look like a bone tumor is the chronic abscess, often referred to as a Brody's abscess. Another example. And here's some more examples of the various appearances of infections. And that concludes the overview of the World Health Organization classifications of bone tumors.